Good afternoon, everyone, and thank you for joining us. Can everyone see my screen okay? I'm seeing nods. All right, couple of housekeeping things before we dive right in. Again, this presentation is going to last about an hour, and then we're going to follow it up with an open Q&A. So if you have any questions, please feel free to post them in the Q&A section. We also encourage you to keep the chat and discussion going, and we will do our best to try to catch all of the questions within there, but also know that if anything is missed or if something comes up later, reach out to the We Honor Veterans team and we'll be happy to get you some answers on whatever you need. As usual, the recording will be posted on the We Honor Veterans website under the Trauma Informed Care Resources page. We will, of course, be sharing the slides. We will also be sharing an additional resource sheet that our dear colleagues at the VA were kind enough to provide with us. On that page will also be the updated screening guide for you level 5 and level 4 folks as well. All right, so without further ado, let's go ahead and get started. All right, our presenters today are a mix of VA subject matter experts as well as our community provider friends. I'm very pleased and happy that Mandy Anderson from Heart of Hospice, who is both a member of NHPCO's Trauma Informed Care Work Group, but also a level 5 We Honor Veterans partner, is able to join us as well. All right, so to kick things off, we just have a couple of polling questions to get a pulse on our attendees. All right, so question 1, previous trauma, whether during military service or not, can impact a patient's quality of life in their final weeks to months. If you have observed how previous trauma has impacted one of your patient's hospice care, please share your discipline with us below. The second one relates to your level of comfort in effectively screening and referring veterans on hospice that have been impacted by trauma. We greatly appreciate you responding to this question so that we can get a good pulse at the end as well. Okay. Go ahead and share the results. Okay, so it looks like a majority of you are other. If you'd like, you're welcome to enter that in the chat box. As far as comfort level goes, it looks like it's a pretty well-balanced response right there. All right, so a couple of objectives today. I know that all of you received these in the registration, but just to quickly go over one more time, the main objective for today's presentation is to make sure that you are able to identify and incorporate at least 2 questions to screen for distress related to PTSD and moral injury. Next, we also want to ensure that all of you are able to apply the techniques learned in this training to assess the spectrum. And then last, but certainly not least, we want to make sure that participants and anyone who views this later on is able to identify and apply the steps needed to connect veterans with VA telemental health expertise. Okay, so I would like to go ahead and hand things over to Dr. Jordana Meyerson, who is a palliative care physician with the VA.
Thank you very much. So I'm just going to talk a little bit about some background of trauma. And just on to the next slide, please. Yeah. So I think it can be helpful to approach care, assuming that many who come into our care for hospice might have had a history of trauma in their lives. In fact, psychological trauma is actually quite common. It's estimated that up to 90% of people have had a trauma level life event at some point in their lives. And that doesn't necessarily mean that all go on to have a history of post-traumatic stress disorder or PTSD. But we know that the population for whom we care and are focusing on today, military veterans, are at increased risk of progression to PTSD. It's estimated that up to 30% of Vietnam veterans, about 12% of Gulf War era veterans, and 11 to 20% of our current era war veterans might have had PTSD at some point in their lives. And in fact, these estimates might be underestimates. And why we think and care about this in our work in hospice is that trauma and PTSD can have significant impacts on the end of life process. We might see symptom exacerbation, so things like increased startling, people might be paranoid, vigilant, hypervigilant. They might have negative distressing memories recur at the end of life. They might have avoided medical care for some time, which might have delayed the diagnosis of their life-limiting illness and consequently might impact how they cope with their life-limiting illness. And then something also that I think we see a lot in our work is that people review their lives at the end of life, and they think back over the course of their lives about different things that they experienced. And sometimes that can actually be very negative for somebody who's had a history of trauma or PTSD. And so when we think about providing care to those with a history of trauma or PTSD, our hope is really to think about providing care that will minimize the impacts of trauma on the end of life process. And everything that we do is really targeted to provide what we call trauma-informed care. The other thing that we know is that trauma can really overwhelm someone's ability to cope with their diagnosis. Back in 2014, the Substance Abuse and Mental Health Services Administration created 6 principles for what they call a trauma-informed approach to care. And I thought I would just review those briefly here. So one is safety, which really implies having a sense of physical and psychological safety at all times for those who are coming into our care with a history of trauma. The next is trust and transparency, which really implies being very open with everything that we're doing and all of the care that we're providing to foster a sense of trust, particularly with those who might not have trusted the medical system prior to this. The next is peer support, which is either other trauma survivors or military veterans or those who may have had common life experiences, such as our veteran volunteers who may work with our hospice organizations. Collaboration and mutuality really represents leveling of power differences and letting everyone know that this isn't a hierarchy, that the veteran is at the center of their care and we are walking alongside them, not above them, we are with them. Empowerment, voice, and choice, that represents keeping the veteran's voice at the center of everything that we do for them and encouraging them to advocate for themselves and then helping to foster that advocacy in what they feel is the best and most appropriate care for them. And then lastly, being open-minded and curious about the different factors, whether cultural, historical, gender, that might have impacted their trauma or gotten them to the point that they're at today. And really keeping an open mind about those things and being curious about them. And the other thing to know about trauma and PTSD is that many of the interventions that are used for trauma treatment may not be appropriate at end of life for various reasons. People might not have adequate time to go through the number and amount of treatments that are needed. Sometimes treatments bring up negative memories and can cause more distress. And then if we don't have adequate time to treat those, we might lead to increased distress toward the end of life without being able to put those symptoms into remission. They may be too fatigued or may not be able to concentrate. And so several years ago, a group created what's called the stepwise psychosocial palliative care model. And it goes through 3 phases, where the first phase is where a lot of us work in hospice. It's really palliating things in the immediate sense, taking care of things in the moment. The second is if somebody has a slightly longer prognosis, and that's evaluating whether they're interested in learning new coping skills and learning more about the trauma and the PTSD that might be impacting their care. And then lastly, this is for folks who have a much longer prognosis and do have adequate time to go through those trauma treatments that I referenced. But in thinking about where a lot of us work in hospice, really stage 1 is probably most appropriate. And I think it's something that hospice teams are quite skilled at. So it's active listening and providing support and reassurance. And I think every member of the hospice care team is skilled in that. Direct assistance in solving practical problems. So if somebody really wants to focus on estate planning and taking care of their will, that is something practical that we can help with that will help them feel well cared for and help to minimize the anxiety from their trauma. Making sure that we know what triggers their PTSD symptoms, whether that's asking the veteran or asking their loved ones, and ensuring that every member of the care team knows what those triggers are to avoid triggering the veteran. And then lastly, again, something else we're skilled at is facilitating conversation between care teams and those who are supporting the veteran in addition to the care team. And with that, I will pass on to Mandy Anderson.
Good afternoon, everyone, and thank you so much for being here today. I'm going to be talking a little bit from a field social worker's perspective, a little bit more in the community provider perspective. I always like to take this first from how do I connect this in the field situation. And starting with that is when you're in the home, and it doesn't matter what discipline you come from, you can have interactions that allow you to see that there's a need for trauma-informed care. That information can come from any member of the care unit. As you know, we are looking at our families, our patients, and even their other caregivers, sitters, things of that nature. And so where do we start when we see these needs? And so I like to say, first, consider your veteran care plan. Most of us who are level 4 and level 5 have at least started the process with our teams of discussing, what is a specialized veteran care plan? So make sure that your team has that in place. If they don't, we are going to discuss a few resources you can learn and take it from there. The other thing is make sure that you do include that in-home care team. And what I mean by that are the family, the sitters, the everybody who comes in contact with the patient. Make sure that you're asking them about their opportunities to interact and if they see it or observe anything that could indicate trauma-informed care. Next slide. So I also like to cover a little bit about field interventions versus referrals. Now they'll go through a better scale for this later on, but something for you to think about while you're receiving training today is thinking about the dual prognosis and the dual diagnosis situation. So what is the medical prognosis versus what is the immediate need prognosis for the mental health end? There are some questions for you to consider, but just kind of think about how reactive is your patient? What is their buy-in on the mental health end? So that you're really making sure to take appropriate steps. And finally, I like to discuss the opportunities for us to work together as a team, because coming from a field perspective, that's really important to me. Next slide. That team, of course, includes your hospice team, but we do also have other resources. Today, you're going to learn a lot about VA resources that are going to be available to you, but we also have our NHPCO, We Honor Veterans Trauma-Informed Care Planning Guide, which I do believe I just saw pop up in the chat. If you've not referenced it before, those of us who are level 5 use that guide to create our care plans. So it's very important for us to know how those interact with our teams and teach our teams about those opportunities. But the other thing I like to encourage people to do is not forget about your other layers of support, your veteran volunteers, music therapy, art therapy. Coming from a volunteer management background first and then moving into social work, I have a huge heart for our volunteer programs. Make sure that you are including your volunteer managers in opportunities to take care of your community. And with that, I will be passing it off to Dr. Sadie Larson, who is a VA psychologist.
All right, hello. Well, thank you for having me here today. So I'm going to give a little bit of background on PTSD and moral injury, and we'll start with just some definitions. If you could go to the next slide, and actually to the next slide as well. So when we start talking about PTSD, I'm going to be talking about the DSM-5 definition of this. And so we start with talking about what trauma is. So you'll note that trauma, according to the DSM-5, involves these specific things: that the person was exposed to actual or threatened death, serious injury, or sexual violence, whether directly experiencing that, witnessing it, or learning about it happening to a close family or friend. And so for most people, actually, most people will experience one of these types of events at some point in their lives. Although not most people don't go on to develop PTSD. They may have some initial symptoms in the immediate aftermath. If you could go to the next slide. So you'll see that there's this kind of range of things from daily hassles, stressors, up to major life events, which can be actually incredibly stressful, things like divorce or losing a job. But when we're talking about trauma as defined by DSM, these are the types of things that we're talking about. And so you'll notice that things like war zone exposure certainly count as DSM-5 trauma. And that's oftentimes what a lot of people think of, but that's really not the only or not the most common type of trauma. So physical or sexual assault, for instance, is a common trauma type. And that can include military sexual trauma, which just means sexual assault or serious sexual harassment that occurs during the military. And that's actually a common type of trauma when we're talking to veterans, especially women who are veterans. But this can also, of course, include things that don't relate to combat or even to the military at all, such as accidents, racially based traumas, and other types of things. Next slide, please. So moving on then from the types of events, for people who experience that initial trauma and then go on to develop PTSD, these would be the types of symptoms that we'd be talking about. And note that there's a really wide range here. There are 20 symptoms. You don't have to have all of them. So PTSD can look like a lot of different things. But there have to be these things. There has to be some type of intrusive or re-experiencing symptom. So that can be things like frequent unwanted thoughts of the event, nightmares of the trauma, or having a flashback where they feel as if they're really back at the time of the trauma. Some of these nightmares will cause people to lash out in their sleep or not be able to get back to sleep. They have to have some type of avoidance. So things like really not wanting to talk about the event or avoiding things that remind them of it, such as a sexual assault survivor avoiding men who remind her of the perpetrator, or avoiding medical care where she needs to be touched in an intimate way. Then the third type of symptom is changes in mood and thoughts. This is a pretty broad grab bag of symptoms. Can be things like thinking I can't trust anyone, which can be easy to confuse with delirium-induced paranoia and which might manifest as difficulties in working with the medical team. Can also be expressions of aggressive behavior. And at the end of life, this can become exacerbated because of difficulties with inhibiting behaviors. So this symptom may be the one that's most obvious to other people, even if it's being caused by intrusive memories. And finally, the last type of symptom is alterations in arousal and reactivity. So that refers to being more on edge, always feeling that you have to be alert to danger. And that can mean that particular noises may lead to strong startle responses, and that people with PTSD can have difficulty with having their back to an open door or not being able to see an exit clearly. And that heightened anxiety can also lead to other difficulties like trouble sleeping or concentrating. So that's PTSD. This can also present as subthreshold PTSD, where people may have some but not all of these symptoms. And that may be more common at end of life, and yet still be clinically relevant, even if not meeting this full criteria. Next slide. So the concept of moral injury is a relatively newer concept than PTSD, and so it's still being defined. The idea of guilt and shame in relation to wartime experiences has been written about for centuries, but we're really just in the last decade researching how to most accurately define moral injury and treat moral injury. So the definition that seems most helpful to me is having experienced an event that transgresses deeply held moral beliefs and expectations. So as with PTSD, there's both an event and a response. So here, moral injury is the response to that event, and it can include psychological and spiritual impact of that event. Next slide, please. So what types of events might lead to moral injury? They could involve acts of commission or omission. So for instance, sometimes veterans may feel guilty for not killing in war if that led to other problems for their team, for instance. Some have to forgive comrades for unjustifiable acts that they felt powerless to confront. Non-combat veterans sometimes feel guilty when they've seen fellow soldiers volunteer for dangerous missions, maybe volunteer and then be hurt or killed. Nurses and medics can feel guilty about life and death decisions that they had to make, often under quite difficult circumstances. Others have felt guilt for killing women or children or committing friendly fire. And some feel not guilty, but betrayed. For example, betrayed by leadership if they felt that they were given commands that were negligent or led to harm. And these examples, you'll notice, mostly focus on combat because that's where a lot of the attention has focused so far on moral injury. But for instance, in the pandemic, there's been more talk about the moral injury of frontline healthcare workers who felt that they couldn't provide optimal care during times when hospitals were overwhelmed. So again, this concept of moral injury doesn't apply only to veterans. It just has sort of received the most attention there so far. Next slide, please. So I mentioned that moral injury involves not only an event, but a response. And so some people, like with PTSD, some people will witness awful things in war and be able to make sense of them or leave them behind. This doesn't leave an injury for every person. But for others, they may be left with these deep feelings of guilt, shame, anger, disgust, or contempt. And those feelings can be pointed toward themselves or toward other people. So when they're significant, they can lead to thoughts of suicide, disconnecting from others, feeling as if they don't deserve to be happy, or to worries about the afterlife. And this can be associated with things like depression or substance use. Next slide, please. So I'm presenting these two things, moral injury and PTSD, as separate, but there is a good deal of overlap between these. So an example here might be a combat veteran who witnesses a good friend killed in combat, at which point his own life is in danger. He's so enraged that he then seeks revenge by killing a civilian. So he might have both PTSD related to the fear of seeing his friend killed and fear for his own life, and moral injury related to killing someone else. So you can see that these two things can overlap within a single event or string of events. And so what does this mean? To simplify a little bit, this means that PTSD is often related to life-threatening or sexually violent events, whereas moral injury can be related to events that challenge our sense of moral order or our own integrity. And so for that reason, they tend to lead to more fear-based emotions in the case of PTSD, and more guilt or shame-based emotions in the case of moral injury. And for that reason, you might want to ask two different types of questions to open the door to hearing about each of these types of events. And that leads us into the next portion of our presentation. So Doug Lane is going to join us. He's a geropsychologist specializing in working with older adults in the VA, and he'll talk a little bit more about those kinds of questions that you might want to ask.
Thank you very much, Dr. Larson. So next slide, please. So we wanted to send people away today with some really concrete tools and mechanisms for screening for the presence of PTSD or other trauma-related symptoms in your settings, recognizing that there's a wide variety of settings out there in which the screening might be conducted. So we wanted to make it as generalizable as we could, as well as concrete. So what you see here are 2 screening questions that we developed based on principles that have been talked about previously, putting the veteran at the center of their care, recognizing that that the end of life and dealing with these issues at the end of life is a special context. So the first question, as you can see, tries to get at the possible presence of a traumatic event in the person's history. So we ask, as people live with serious illnesses, they sometimes experience reminders of prior scary or upsetting events. And has this happened to you? And then the second question is designed to screen for the presence of concerns around moral injury. So have you felt guilty or bothered about events that previously happened in your life? So we'll talk a little bit, though, about using these questions in a larger context of a clinical interaction with a veteran who may be experiencing these concerns. Next slide, please. So we know that if we go in and ask these questions in a clipboard or in a box checking manner, that we're not going to have the best outcome, and we'll probably lose people who we could otherwise help. So we start first by thinking about the foundation for having this conversation. The first thing we think about is our own selves and who we are bringing in the room with us, so to speak. What this means specifically is being aware of how I feel about even broaching the subject of trauma with someone. Is there something in my own history that makes that difficult for me to bring up with another person? Do I feel uncomfortable, like I might be invading this person's past? Do I worry about what I might hear in the form of this person's account? So being aware of how I'm feeling about doing what I'm doing and how that might affect how I go about doing it. But also on a very practical level, being aware of the logistics. Do I really have time to do this now? Do I have the time to engage with this person if they indeed bring out some significant material? Or am I pressed for time and I'm just going to be sitting there hoping that they say no to everything so that I can move on? Also, do I have the appropriate private space? It's very easy in some settings for privacy to naturally erode. And so sometimes we have to be very attentive to that and reestablish that privacy for a conversation like this. So we also talk about conducting the screening as part of a larger conversation. So engaging the person in an interaction and then embedding the screening in the midst of that interaction. So you'll see, as I go through some examples here, we talk about transitioning in and out of the conversation, and that's what I'm referring to. Because we know that how we conduct the screening can minimize or maximize the person's likelihood of engaging with us and accepting any care that they might want. We also know that if we really blow it, if it's handled very poorly, it can potentially re-traumatize a person. And so that's why we work so hard to leave the person in the position of decision-making around all this. This is not to raise any anxiety at all. It's intended to simply underline the importance of treating this as a conversation and a clinical interaction, as opposed to 2 quick screening questions to go through. And lastly, we encourage being open-minded. As has been discussed previously, you may hear people who talk about significant traumatic experiences who say, but I'm okay with all that, it's over now. And they have no interest in receiving care for that, even though in our mind, it sounds like they experienced something horrific. Or on the other side of it, they may request care for something that to us might seem minor. but be open-minded about it because it may represent all that the person's willing to bring out right now. It may represent the tip of an iceberg. And we know that what is traumatic sometimes is very subjective. So with that as a foundation, thinking about specific approaches, we transition into the conversation by simply asking the person if they feel like talking at all with me today, and is that okay? If the person says no, I'm going to affirm that that's just fine. They don't have to talk with me. If they're feeling tired today, or if family's coming, or there's something else going on, thank them for letting me know, suggest another time that we might talk, and give them a specific time to see if they might be interested in coming back. The other thing that I need to be aware of, though, is that the issue at hand, again, may be me and who I'm bringing in the room. And so I need to consider whether this person might be more comfortable talking to another person. So for example, me as a middle-aged white male might find myself speaking with an older Black man who would be more comfortable talking with another older person rather than me. Or a woman veteran might be more comfortable talking with a man veteran. So these kinds of factors that I need to be aware of. However, if the person says yes, I'm going to go one level deeper, monitoring our rapport, making sure that the person seems comfortable with me. And I'm going to go to the next step and just explain generally that we always want to make sure that we're meeting the needs of the people for whom we provide care. So this isn't about targeting this veteran. This is something we do for everyone. So we want to identify those needs as soon as we can. And then to do that, we ask some questions from time to time. Certainly we might ask it at admission into the hospice service. We might also, though, ask it a few months later if we felt like we might need to. So we ask some questions from time to time about certain various issues and offer to help if we identify any needs. I have some issues I thought we might talk about today. Many people have had experiences in the past that were difficult. I was going to ask you about any of your past experiences that were painful and whether they still bother you. Is that okay? So what we're really doing here is obtaining this veteran's informed consent to participate in the screening by identifying that some of the questions that we're going to ask might have some difficult answers. And again, giving them the autonomy to say yes, but later, or no, or okay, let's do it right now. So next slide, please. So we've asked our questions. The person said, yes, we can talk. And we've asked our questions. And so we want to think about some common scenarios that might emerge. Maybe the most straightforward one is the person says, no, I've never had any experiences like that. I'm not troubled by anything. So as always, we thank them for talking with us. They just gave us part of their history that they chose to give us, and that was a gift. And validate that, again, that not everyone has had those kinds of experiences, or if they have, they don't necessarily continue to bother us. Sometimes they do, sometimes they don't. And again, making sure that the person is comfortable, make a few minutes of small talk before disengaging, and then going on about the day. If the person responds yes, they have had experiences like that and they continue to be troubled by them, then we let them know. Again, we thank them for letting us know about that, and we validate how difficult it can be to talk about those things. And then we make the point that there's help for that. Absolutely, in the hospice setting with the staff and volunteers and caregivers there, and that there's also additional help that can be brought to bear from the VA. There are staff at the VA who specialize in helping with these kinds of issues, and we can access that care for you. And it's important to point out too that the treatments available these days are state of the art, especially for older veterans. They may not really understand how psychotherapy, for example, works, or they may have a very old, outmoded view of it. Furthermore, we leave open the idea that not everyone wants to address these experiences, though, and that's okay too. Sometimes people might want to leave it as a part of the past, and they don't want to bring it back up again. And we ask the person what they think is best for them. And if they would like to think about it, we volunteer to come back another time. So our role is to offer and be very careful not to push. And then lastly, we want to find out, are there things that the staff or the caregivers, the volunteers at the hospice service can do to support that veteran? For example, are there things that that veteran wants us to know about how their past experiences affect them now? For example, if a woman veteran has trouble being touched after a history of military sexual trauma, that might be helpful for our staff to know. Are there things we need to do differently, as I say, in how we go about your day-to-day care? If you seem upset, is it helpful for someone to ask you about it, or is it better just to give you some space? So we try to ask for very specific things that at the service level can be done to help that veteran. And then lastly, we explain to that veteran how to access immediate support in any given setting if it's ever needed urgently. Okay, next slide, please. So perhaps a more difficult scenario is silence. I ask the questions, and rather than responding one way or the other, the veteran just sits. Maybe they look down. This can be due to emotional reasons. It's difficult material. It can also be due to cognitive reasons. There are a whole host of illnesses that involve slowed cognitive processing. And so it can take the veteran some time to put their thoughts into words, to generate speech, to think through a response. There are medical reasons, fatigue, for example, etc. So we sit with the person for a little bit and inside of ourselves do the best we can to tolerate the silence, reassuring ourselves that we didn't do anything wrong, we haven't blown it. But if the person doesn't respond, we can, after a bit, cue the person and just say, I know these things can be hard and I don't mean to push. Would you like me to come back? And if the person says yes, we again affirm that and we set a specific time so the person knows when we're coming, and we transition out, making sure that the person's comfortable. If the person says no, they actually don't want to talk about any of this after all, we validate that, make it clear that we are always available should they ever change their mind, and that in addition to us, the VA is there too, if they would ever like to go down that road. Making especially sure that the person is comfortable and okay before we go, and ensuring that any available caregivers keep an eye on that veteran for a day or two after, just to make sure that the veteran is all right after what seems to have been a hard interaction. Next slide, please. So probably the scenario that might create the most angst is the person becoming upset, the veteran becomes upset. So we want to address any immediate needs that may be contributory, for example, pain, and then offer them a choice. I know these experiences can be upsetting to think about. That's very real. Is it best for you to push through, or is it better to leave this topic and just focus on helping you feel better right now? So we give them a choice. And if the person says, no, I need to get this out, which sometimes people do, we will advise following the process discussed previously and being prepared to provide the psychological first aid that we've talked about as well. And also consider whether there might be other staff, caregivers, volunteers who could be helpful if they were available, or who could respond perhaps by coming by the next day, something along those lines to help support the person. And always certainly engage the person in calming activities, psychological first aid, to bring the interaction to a close and check on them. Again, knowing that this has been a difficult interaction. So next slide, please. So I want to highlight the difficulty of this work for the people who are conducting the screenings, and always just remember that these are painful topics to talk about, and the people who are doing them can certainly feel that, especially over time as they talk to more and more veterans about more and more things. And so it's important at the front line level for us to support each other and make sure we're doing okay in this work, and then also for those up the chain of command to be aware and keep an eye on the caregiving staff down in the ward and in the home, so that everybody is aware of how everyone else is doing, because this is hard work that we do. So with that, I will turn it back over to Dr. Larson.
Thank you. So I'm going to talk a little bit now about assessment, which we could think of as a potential next step following those initial discussions. So these screens and symptom severity measures, they can be that follow-up and help you get a better sense of the full picture of how trauma or PTSD may have affected someone and the current symptom burden. So the one here, the PC-PTSD, is very brief because it's designed to be used in primary care, thus the PC-PTSD, or in other places where you'd want a quick screen. And the PCL or PTSD checklist is slightly longer. So it's 20 questions, which all map onto one of the symptoms of PTSD in the DSM-5. The life events checklist, which I listed at the bottom, is a list of potential traumas. So you may think about which of these might be a helpful follow-up to some questions. If someone does endorse having experienced a trauma that's still bothering them in some way. And it may help to consider, in the case of older adults or with dementia, to supplement this with a comprehensive chart review or speaking with family members as well. So all this information can be helpful if you're referring to VA mental health. Having a score on the PC-PTSD or the PCL will be more easily interpretable to them in terms of symptom severity. Those would be scores that a lot of VA providers would be familiar with. So in looking at the next slide here, which outlines the PC-PTSD, this is just to give you a sense of one of these screens. If you can go to the next slide. So this is the shorter screen. And after assessing for the experience of a trauma, you would then ask these 5 questions. So with the first one, for nightmares, for instance, you're looking for things like a direct replay of the trauma or something thematically related to the trauma, as opposed to a general distressing dream. For the second one, avoidance, often this looks like never having talked about the event, or it can look like avoiding things that remind you of a trauma, something like crowds. The third one can look like easy startle response that's really more than a normal startle response. Anyone would be expected to have some startle response, or being overly watchful, like feeling that you can't sit in a restaurant with your back to the exit, or always having to scan a setting to see where those exits are in case of danger. For the fourth one, feeling numb or detached, we're really looking for ways that people are not engaging socially or can't feel their normal feelings anymore. And this should be related to the trauma. So if this just started happening after retirement, for instance, or if they felt this way their whole life, even before the trauma, then this may not really kind of count towards this symptom. And last, for the guilt question, we're not talking about appropriately blaming a perpetrator, for instance. Rather, we're getting at blame that doesn't make sense. So like a survivor of assault blaming themselves for having trusted the perpetrator, or someone blaming a leader who led them into an ambush that they couldn't have been expected to know about, rather than blaming the person who launched the ambush. So that gives you a little flavor of PTSD scales. If you go to the next slide, for moral injury, unlike PTSD, again, there's very little consensus about how to best assess for moral injury. And remember that this differs depending on whether you're trying to get an overview of events that they've experienced or the reactions to those events. So there's not really one best measure. And again, most of them focus on combat and not on civilian events. But that said, I wanted to show you at least one of these scales, the moral injury events scale. If you can go to the next slide, it's one of the more commonly studied, and this will give you a sense of some of the questions on this scale. Again, like many, it's centered around a military context, and unlike with the PTSD scales, there's no consensus around, what level is kind of a cutoff for moral injury severity, but you'll see that the information from it it gives you a lot of rich clinical information and could be enough to start a conversation around what would be helpful to the person or how distressing this is. And so that takes us into the next section, which is thinking about when might we want to refer to someone else. So I'm going to start with talking a little bit about, I presented some of the scales that give you a sense of severity and help to communicate to other people how bad things are. But just to give you a brief sense of severity, I want to show you a spectrum of various symptoms. And so on the lower end here of the spectrum, we're more likely to see those symptoms or reactions that can be responded to on your own team by you and other members of your team. You can see that these are things that could still be very distressing, like thinking about a trauma, feeling irritable or jumpy, or feeling regret about your own behaviors during a trauma. Whereas when we look at the higher end severity, you can see that these are things that may be more distressing and maybe more obvious to other people too. So things like being so distracted by trauma reminders that it gets in the way of conversation, or adamantly refusing to talk about something, having self-hate, being on constant alert for threats in the environment, leading to aggressive behavior in response to perceived threats, or having guilt or shame that feels just unbearable. And so if you're looking at this higher level of severity, what might you do? And so we wanted to outline things that you might consider in when might it make sense to bring in VA care in some way. And so the first question to ask here is, does the veteran want to address PTSD or moral injury? As Doug talked about, if they don't want to, that is fine. This is not the time in life to try to push this issue. But on the other hand, if they do, even if it doesn't look like symptoms are severe, go ahead and make the referral, because often we can only see a small portion of the symptoms, or the veteran may be avoiding telling us about the event or how much it really bothers them. So if the answer is yes, move ahead with addressing it either within your own team or with the VA. And so the next things to think about, one is, how severe are these symptoms? Are they causing significant distress or disruption, whether to the medical team or to their ability to connect with loved ones? And on the PCL, for instance, a cutoff that's often used is somewhere around 31 to 33, above which we would think of this as clinically significant. The next thing to think about is, are these symptoms causing significant distress? So really, if any of the above is yes, then this is an appropriate time to use interventions on your own team. Things like active listening, relaxation skills, and environmental changes to make the person feel more safe and secure. This can be a good time to bring in any of your team members who have some expertise in trauma-focused care. And all of that could be done as part of your team. So now let's say that you've done all of that, but either your team is not feeling they're prepared to treat this level of severity of PTSD or moral injury, and maybe those initial interventions were not enough and the person is still quite distressed. So there are two main options next. Let's say that symptoms are somewhere in the moderate range of the scale, or you just feel like you need a little bit more help to best care for this person. This can be a great time to talk to the PTSD consultation program, which Fanta will discuss next. And this is also a good option if the veteran has distress, but they aren't interested in getting VA care. This consultation is with you as the provider rather than with the veteran. On the other hand, if the severity is more than is really manageable within your team, then this is a good time to consider VA telemental health if the veteran is open to it. And it might be a good time to try both. So the telehealth for the patient to directly connect to the VA mental health provider, and the PTSD consultation program to help you as a provider or as a team to provide the best trauma-informed medical care in the meantime. And so now I'm going to turn it over to Fanta Gibson, who's the palliative care coordinator at the Danville VA, to talk a little bit more about some of those available resources that I just previewed.
And thank you, Dr. Larson. So hello to everyone. And as she stated, I'll be bringing you some information today about connecting to VA resources and support that's available. So as you can see on this slide, we're going to discuss resources that are available to you specifically as the clinician or as the hospice provider and care team that's taking care of the veteran through the PTSD consultation program, as well as the crisis line, which is available to veterans as well as to non-veterans, such as their caretakers, to get information and support. And then also information specifically for veterans that would need to be enrolled within the system here at the VA. And I'll also be providing information on that in general enrollment process. So first, I'm going to talk about the Veterans Crisis Line. As you can see, there are multiple modalities that you can use in which to connect with the crisis line. This includes via phone, text, chat, and this is a service that's available 24/7, so every day of the week. And it also has some of the responders that answer may also be veterans themselves to help provide better feedback to the veterans needing the support. And as you can see on the next slide, this is an example of if you were to do the crisis chat, what it may look like if you were doing it online. And again, this is a free, anonymous, confidential resource that's available to the veterans as well as to those who provide support to the veterans if they have general questions. And it's some may contact it for if they're having suicidal ideation, but it's not just for those who may be having thoughts of suicide. You can also contact it for the veteran, him or herself, or also for you or the caretakers if they have questions generally related to the veteran is experiencing a lot of chronic pain, anxiety, depression, sleeplessness, or disturbing memories of the tour of duty. And sometimes, even though the veteran may think that some of these issues have been resolved earlier on, once the veteran is on hospice care, for example, if they experienced maybe a near-death experience while they were in service, being on hospice care and being faced with, that life-limiting death situation again, that may bring up recurring dreams or nightmares. So this may be another resource that they may want to utilize to have somebody to talk to about that. So on the next slide, I'm going to talk about what you'll need to have available if the veteran that you're assisting is not enrolled in the VA, but they want something or some type of care or support from the VA and they need to get enrolled. So you want to make sure that they have their social security numbers or social security cards available for themselves, as well as for anyone else that's in that household and their qualified dependents. They will also need to have their military discharge paperwork, which we typically refer to as their DD-214 or their separation documents. Also, if they have any other health insurance coverage, including Medicare or other private insurance or Medicaid, you'll want to have that available as well. It's also optional, but typically the form asks including their household income. So they would want to be able to have that available as well if you're going to assist them with completing the forms or if they're going to do it themselves as well. And then the next slide gives the different options of how they can apply. So if they can do it online, so they definitely want to make sure that they have that information available, including like all those numbers from their social security numbers, those figures for their finances, so that they can complete the online form easily. There's also a number that they can call and apply through, or they can do it by mail. And the name of the form that they're going to complete is called the it's called the 1010EZ form. And this again is for veterans that are not enrolled in the VA system. If you have a veteran that has been enrolled in the VA system and they regularly get care there, there's another form that's called the 1010EZR. And that's something that it's a shorter version of this form. And it's just basically like an annual update that they can do. Okay. So next, I will talk to you about the PTSD consultation program. And so this is a resource that is available whether you are very skilled in providing post-traumatic stress disorder treatment and even training others on providing maybe that treatment, or if it's something that's new to you for having a patient that has PTSD, this program has resources available to you as the clinician to better assist your patients. And so the next slide is going to be a video. There's no word speaking, so you have to read just to make sure you're paying attention. So you can press. Thank you. And again, this is a free program that's available to you as the clinician, as the healthcare team that's taking care of the veteran that is exhibiting signs of post-traumatic stress disorder. This is kind of the disclaimer here. So this is available as kind of an extra support or guidance in providing consultation to the veterans that you're treating within the hospice program. However, it does not replace what you are doing. You are still the primary care team for that veteran. Some may kind of liken it to discussing a difficult case with a colleague, and I think it can be beneficial for any hospice program, but probably particularly to those that may have maybe only one mental health person within their agency, or one or two. So for smaller agencies, having another person that you can kind of bounce ideas off of and get feedback from, so it can be very beneficial. And so the following, this list, there are multiple frequently asked questions videos. So this particular one that I'm going to have played is a 2-minute video, and it addresses the question of, can PTSD consultation program be helpful to me? And it talks about how this program can be beneficial to various disciplines working with veterans with PTSD.
We want the consult program to be open and accessible to everybody. So if you're brand new and you're a brand new provider and you've just learned cognitive processing therapy and you have some questions about it, you should feel free to call us. If you're an expert and you've been supervising people using cognitive processing therapy, but now you have a really complicated case, you can call us as well.
A social worker, a primary care physician, a nurse, a mental health provider who's treating addictions or pain or something else.
We want to reach chaplains and people who work at receiving desks who might have questions about contact with patients with PTSD and offer them consultation.
I think originally my thought was I don't do intensive PTSD treatment, so I'm not going to use this service. As I've worked more and more in the primary care clinic and realized how much PTSD I saw, I realized that I need consultation and how to deal with PTSD in the way that or in the place that I am in the treatment process.
You could just be providing clinical social work services, and you might need some advice or feedback on how to better engage a veteran, how to work with their treatment team about what might be best for them.
I would highly recommend calling, if nothing else, just to talk to another person and get a different perspective. And hopefully what I got out of it was feeling that you're supported by your colleagues.
Thank you. And I see somebody in the chat noted that they've used the consultation before and that it was helpful. So that is awesome. And again, you can click on that link and it has multiple frequently asked question videos that you can scroll through and take a look at to see if it may address a question that you may have about how this program can be beneficial to you. So next, I'm going to talk about accessing telemental health. And this is for veterans that they would need to be enrolled within the VA system in order to utilize this service. There's opportunity to have a VA Video Connect, which is an app that promotes anywhere to anywhere care. Again, I already gave you information on getting the veteran enrolled if he or she is not already enrolled. There are telemental health hubs available in which there are mental health specialists, and these hubs are available in different sections of the country. And so they have mental health specialists that are available to assist veterans, and they can schedule them for video visits. And then also, I also listed another resource, and this is for if you have a veteran that's already enrolled and they already have a primary care team within the VA, you can use that VA facility locator to locate your nearest VA system, and you'll want to ask the veteran what the veteran's primary care team is. Typically, we may refer to that as their PACT, P-A-C-T team within the VA. And that can help to get you started for any services that you may need to get them. And then also within that VA locator, you can also locate other types of facilities such as the VA cemetery or the different national cemeteries that are available. So on the next slide and final slide, I want to talk a little bit more about the VA digital divide consult and telehealth care that's available for veterans here at the VA. So the digital divide, it refers to the gap between the demographics and regions that have access to modern information and communications, including technology, and those that do not have access. So some veterans and others may not have access to maybe internet service or internet connected device that they can use within their home or within their even community. So the VA is working to bridge that digital divide by providing tablets or other devices to those veterans that they can utilize in order to connect to the VA via video from their home or wherever they're having this their visit from. And please note, typically it's the social worker that's going to be the one that's putting in, it's called a digital divide consult. If you're calling to ask about or make a request, please let them know if the veteran is on hospice care, because the process can take a little bit of time to get them to get the tablet or whatever the device is out to them. However, when you let them know that the veteran is on hospice care, they do try to put a rush on processing that consult. So I want to thank you all, and I hope that this has been helpful, and I will now turn it back over to Catherine Kemp with NHPCO.
Thank you so much, Fana, and all of our presenters. We're going to wrap things up with one more poll. And again, if you have any questions, comments, experiences that you would like to share, I know many of you have been active in the chat. Also, feel free to enter anything in that Q&A box. Okay, so we're going to go back to assessing how comfortable are you in effectively screening and referring veterans on hospice that have been impacted by trauma. Just give you a few more seconds to answer. Okay. For some reason, my poll does not want to share. I don't think anyone is able to see this. Oh, there we go. Okay, sharing results. Yeah, we see the numbers have changed actually quite a bit, particularly in the not comfortable realm. So very thankful to hear that, is that means that this presentation was useful and we were happy to provide some practical tools and resources for you today. Okay, I know we're right at the end of the hour and some people needed to jump off. Again, if something comes up that you would like for us to ask our colleagues within the VA, or you would like to share some feedback, please reach out to the We Honor Veterans team. We'll be happy to get you connected, get those questions answered, and share anything that you would like. So we want to thank the VA members of our work group, as well as our contributing community hospice partners. I would also like to send a big thank you to NHPCO's Trauma Informed Care Work Group, who really did a lot of the heavy lifting and updating that screening guide that is available on the Trauma Informed Care website. I know Em has entered that link a few times in the chat box. Thank you, Em. And again, all of the resources that were mentioned today will be available on that Trauma Informed Care webpage. A recording of the webinar will be available by the end of the week and posted on our homepage under the latest happenings. And along with that, we will of course be sharing the slides, as well as that reference sheet that has a list of other things that we think could really be helpful. So thank you to Dr. Scott Shreve and others for providing that information as well. And again, of course, thank you for participating and for attending. If there are any questions or comments, go ahead and enter them in the Q&A, and I'm going to get started. Okay, will there be handouts? Yes, just went through that. Okay, we have another question. In HBPC, we have observed that as dementias progress, veterans' PTSD symptoms become more evident and have the potential to be a safety concern, especially during sundowning periods or nighttime due to war zone hallucinations and or paranoia. Is this something that others have seen as well?
That's not uncommon, especially depending on how advanced the neurocognitive disorder is, and also depending in some ways on the type of neurocognitive disorder it is. So for example, dementia with Lewy bodies, the dementia that goes with Parkinson's disease are commonly accompanied by visual hallucinations. And so sometimes that can be part of that exacerbation of the PTSD symptoms. So it's not unusual. Depending on the degree and the advancement of the cognitive disorder, we think in kind of two types of interventions. One would be pharmacologic, for example, a medication to deal with nightmares. The other, though, would be the non-pharmacologic. And so if we're concerned about visions, hallucinations, things like that, we might, for example, make sure that the environment is well lit. The curtains are open, there's plenty of daylight. We know that shadows and things like that can trigger hallucinations. If we're do a good sweep of the environment, look for any trauma pertinent cues that may be causing difficulties for the person. Think about how we approach the person and how we interact with them, and think in terms of those issues as well. It is possible to use, again, depending on the degree of progression, basic psychotherapeutic mechanisms to help people with cognitive disorders who are experiencing those symptoms. Behavioral activation can be very helpful. Engaging the person in meaningful activities can be very helpful. Depending again on especially the degree of loss of executive function, and the ability to use some of the basic skills, for example, in cognitive behavioral therapy, that might be an option. And then as well, there can be deep spiritual needs for people who have cognitive disorders. And so we've had interventions, for example, for veterans who had a lifelong deep faith belief, to bring that keep that in their life. Again, some very powerful messages there around forgiveness and safety and things along those lines. So especially when you're talking about cognitive disorders, each person is really, really their own unique fingerprint, so to speak. And so the interventions have to really be personalized. But depending on the degree of progression, they can pull from all the usual resources we might think of.
I just wanted to add with the safety concern also, in case sometimes you may have couples that are still sharing the same bed. So if the person is starting to have those nightmares, that may be an instance where you want to reintroduce or getting a hospital bed in and separating that person, just to make sure that they're not reliving their nightmare and maybe affecting their spouse by inadvertently choking or hitting them during that time when they're in bed together.
And I would say too, kind of thinking about that, look for maladaptive coping mechanisms that the family or whomever may have thrown in the gap in an effort to try to help. So for example, using alcohol. I've seen more than one situation of veterans with cognitive disorders and PTSD who are drinking heavily to try to deal with it. Or smoking a lot, or doing other things that we know probably are making things worse.
Thank you for that. Let's see, the next question revolved around more practical matters. Yes, for those of you VA folks looking for credit, if you are having any issues please reach out to the VHA train folks. I know M entered that information in the chat box. And for you, We Honor Veterans partners, this will of course count towards one of your educational requirements within your partner activities, no matter what level you may be at. Okay, so moving on to the next question. On the digital divide consult, I have always wondered why there isn't a palliative care option. We often need access to care a little more quickly also.
So we have a separate palliative care consult within the VA. So if there is something that they're needing specifically from the palliative care team, they can put that consult in for that. And then if the need for the digital divide consult comes up, then the palliative social worker or they can kick it back to their primary care team social worker can get that process started.
Okay, are there any other questions? I know a lot of people were entering comments surrounding the previous question. Thank you very much. You provided some ideas for interventions we have not explored for one veteran in particular.
Yeah, there was another related question that was for veterans with decreased cognitive ability. What is recommended? And really, Doug, I think, already gave a great answer for a lot of that. I just wanted to mention too that depending on sort of the level of neurocognitive disorder and the kind of time frame that we're talking about, this goes back to the phased model that Dr. Meyerson talked about at the beginning. It can be still helpful to do a course of trauma-focused psychotherapy potentially. So if we're talking about severe neurocognitive disorder, those typically aren't going to be indicated, but if it's more on the mild to moderate range, there is some evidence that those can still be helpful for people with some cognitive decline. But I would also agree with everything that Doug said earlier in terms of the kind of environmental interactions or changes, the kind of basic psychotherapeutic techniques, and sometimes just things like relaxation or distraction used skillfully.
Okay, I'm not seeing any other questions. Again, if something does come in, please feel free to reach out to us. Like to open it up if any of the presenters have any final words. You are welcome to share those as well with the audience. A lot of thanks coming in. Yeah, again, thank you everyone for making the time to be here. Again, we will get all of these resources and the recording up on the website as quickly as possible. Thank you, Marge, for being such a source of support to all of our partners. Again, we want to send a huge thank you to everyone who participated in this, particularly our colleagues within the VA, because we know that this program would be nothing without them. And we continue to be grateful for all of the knowledge and resources that they continue to share with our community providers. So stay tuned. There will definitely be more things coming out over the coming months. And we look forward to continuing this work with you. Thank you, everyone.